Okay.
Good morning, good afternoon, good evening, good night, friends and colleagues from around the world. Welcome to the 2020 Peer-to-Peer Global Dental Interdisciplinary Summit. For our final webinar of today, we are back in Japan and being hosted by Brazil. Dr. Carlos Morao will be our host today. He's a DMD, MSc, PhD, and heavily involved in research and academia. And Dr. Eiji Furuichi from Japan. He has a wonderful topic for us and for the implant world. And he's a very well-known implantologist from down there. So welcome and thank you for joining us. We will help each other get through this presentation as Dr. Furuichi will be talking very slowly. The English language, she's going to be presenting it very slow to communicate that way. With that said, Dr. Morrow, you have the floor.
Thank you,
Yeah.
Dr. Shah. I'd like to introduce Dr. Eiji Furuichi. Dr. Eiji Furuichi core competencies are in periodontics, implants, and aesthetics, and prosthodontics. He had graduated from Osaka Dental University in Japan in 1992. Uh, he's a clinical. He has clinical private. He clinical private office in Kobe, right, Dr. Fuji? And he obtained his PhD in prosthodontics from Osaka Dental University in 2005. And Dr. Fuji has a lot of other things here in our bio. And I'm very glad to be here with Dr. Fuji. Thank you so much for your presence here with us. And I hope we will for sure we will have a very good presentation from Dr. Furuichi. And thank you, Dr. Furuichi. The floor is yours.
Please excuse my English, not so good. I'm very excited to do this. Thank you again for the opportunity. Thank you. Okay? Don't. Thank you very much for taking the time to hear about my cases. I'd like to thank the entire staff of the Global Interdisciplinary Summit. My name is Eiji Furuichi. I'm from Kobe, Japan. Being able to participate as a speaker at the prestigious symposium is a great honor and one of the most rewarding moments of my life. I have a PhD in dentistry and I specialize in periodontology, implantology, prosthetics, and aesthetics. The theme of my presentation is periodontology, implantology, and prosthodontics. I'll show you that teeth can be saved and used in the final restoration process using periodontal resective therapy. And I will show you some clinical cases to talk about what true treatment endpoints are all about. This is a case of mandibular first molar from 8 years ago. The Parkinson involvement is class 3. Regenerative therapy was performed. 18 months after re-entry, complete closure of the Parkinson defect was achieved. This is an amazing result. The patient hoped to rely on regeneration therapy to save her teeth. What would you do? What would you suggest her to do so with this condition? Do you think it is possible to get results like this every time? These articles answer these questions. The answer is no. We believe patients should be presented with a treatment method that has at least an 80% chance of success. We also need to understand the dental forms to achieve aesthetically pleasant and natural endpoints. Here, I listed teeth number 45 through 47 using direct bonding. These are very beautiful women. Since we live in a world that emphasizes aesthetics, we should avoid making their teeth look like this by utilizing 21st century surgical techniques. In addition to provide treatment backed by scientific evidence, we always need to bear in mind that our final outcomes must be aesthetically pleasing at endpoints. These are the final restorations of a female patient in her 80s. The final outcome must really consider the aesthetics. This is the follow-up after 5 years. Everything still functions beautifully. Here is a view at 8 years after prostheses were applied to the full anterior teeth. They continue to function in a beautiful state. Also, it is very important to be able to take impressions correctly. Recently, I often see teeth be extracted and reshaped with implants where they should be able to function for a long time with proper treatment. The most important thing is to make an effort to save teeth that can continue to function. It is also important to acquire the appropriate knowledge and skills to do so. And now I would like to begin the presentation of the crown limiting procedure. I think it's a very important technique, and we often have to use it to save teeth. I'll show you my cases. This slide shows data from an article published in 2004 by Axelson et al. These are the results for how teeth were lost after 30 years of maintenance in more than 550 people aged 21 to 65. The main reason for tooth loss was fracture. Most fractured teeth have screw post or metalcore. These results suggest that although it is possible to prevent caries and periodontal disease, it may be impossible to prevent fracture. The most important thing to consider for tooth preservation is tooth thickness and residual tooth mass. This is the case of a 66-year-old female. Here is the preoperative condition of the upper right molars. Do you think we should extract all of the patient's teeth and replace them with implants? The answer is no. This is a preoperative dental X-ray of the upper right molars. Endodontic treatment was performed because apical lesions were present. Blood control measures were introduced prior to ensure treatment so that the Pullman plaque score was reduced to less than 10%. After achieving optimal hygiene, periodontal surgery was performed. Next, careful and minimal osteotomy was performed until the architecture was positive. Care was taken to avoid exposing the bifurcation except in the area requiring bone removal. We performed debridement and tooth root preparation using the same method as Carnivale et al. Since the caries had progressed to the deep part of the subgingival region, as described by Carnivale et al., the gingival flap was formed and exfoliated with the partial thickness flap, and the bone was removed and reshaped, and the buccal flap was formed. The palatal side was moved, and the flap stump was positioned and sutured to the top of the bone. In addition, the stump of the palatal flap was also made to meet the bone crest. Hayashi Takahashi et al. At Osaka University reported that Baba posts are superior to all other treatment posts with regard to resistance to root fracture, while Sojima et al. At Tokyo Dental College found that for META MMA TBB resin has the strongest adhesive properties of all cements. Here is a comparison of initial and post-operative occlusal view. The width of the alveolar ridge was increased in the area around the missing tooth. As suggested by these articles, for the apartment construction, we used the indirect method to fabricate the fiber post-core and adhere it with for META MMA TBB resin. Roberto Pontoriello and Gianfranco Cannavale reported that gingival growth continued for around 1 year after crown lengthening, with a mean growth of approximately 3 meters. Even if We wanted to start the preparation within 1 year. We needed to wait for at least 6 months before we set a slightly shallow finishing line of the preparation margin. It has been reported that the attachment of connective tissue will be lost if a margin is set up to the point where the connective tissue attachment exists. This has been reported in both humans and dog experiments. We adhere the fiber protocols with for META MMA TPP resin. We took the final impressions 14 months after periodontal surgery. We then made the diagnostic workup and provisional restorations. These are the final processes we did. The final processes are made of the lithium disilicate glass ceramics. These are the final prostheses. We were able to reproduce a very beautiful state. The healthy gingiva is glossy and the finishing margin line is beautiful. Here are the final outcomes. This is the follow-up 16 months after treatment. This is the occlusal view 5 years after treatment. This is the back view. Even after 5 years, the periodontal tissue and the prosthesis still function beautifully. These are the buccal and dental X-ray images. This next patient is a 43-year-old female. It is possible to preserve the teeth in this state. Perform the same crowning technique procedure as before. I waited about 8 months after the operation and took a final impression. In addition, we adhered fiber protocols using for META MMA TPP resin. These are the final processes. We set the final processes with layered zirconia ceramic bridge and crowns. Here is the final outcome. This is follow-up after 5 years. This next patient is a 66-year-old female before surgery. It is possible to save teeth, save G teeth even in this condition. We created a surgical stent. Here, I opened a partial thickness flap to modify the bone morphology. It's important to visualize the shape of the final prosthesis at this point and shape the bone into a positive architecture. We performed suturing. We waited about 15 months and made the final preparations. We made the diagnostic workshop. These are the final preparations. Next, we took the final impression and festival transfer. We performed the trial of the prosthesis in biscuit bag condition. The final prostheses were made of lithium distilled glass mix. Here is the final outcome. Follow-up after 5 years. If we follow the proper procedures, we can maintain teeth in good condition. It is very important to save teeth, but for those with low treatment predictability, it is also important to extract them at an early stage and rely on implant treatment. In today's dental treatment, implant treatment is proved to have both aesthetic and functional predictabilities. This systematic review and meta-analysis demonstrates that periodontally compromised patients had a greater risk ratio than periodontally healthy patients for all parameters. The finding clearly shows that periodontal disease is a risk factor for implant therapy that must be controlled. This patient is a 54-year-old female. Teeth number 35 and 36 were missing. Here, I exfoliated the gingival flap in the lower left of the affected part. Then, I performed a thorough curettage of the bone surface. Then, I placed the fixtures in proper positions where the final prosthesis should come. Then we perform tension-free suturing. However, as the image on the left shows, you see many cases where the antagonist teeth are extruded. In such cases, as you can see in the image on the right, you need to get the occlusal plane back to proper condition by osmotically pushing them down. Considering the lack of keratinized gingiva around the implants and around the teeth where I'm going to prosthesis, I grafted some keratinized gingiva collected from the maxillary plateau side. Here are the final preparations. I took the final impression. These are the cornea abutments. Adhesion was found in the lower left canine and the canine guide was insufficient. So I fabricated a laminate veneer for this canine without preparation. You can see the final prosthesis on the right. This is when I fitted the final prosthesis. Look how pleasing the outcome is. This is the follow-up after 4 years. These X-ray images were taken before the operation, at the setting, and at the 4-year follow-up. 6 years later, the patient teeth remain in good function. Even where there is not enough alveolar bone, we need to be able to perform bone formation. According to this systematic review and meta-analysis, a successful implant therapy requires periodontal therapy and encouragement to stop smoking. Who mouth plug scores should also be controlled at 10% or less. こっちもつけてもいい？つけてる？ This systematic review compares the outcome of GBR with bypass alone and a mixture of bypass and autogenous bone. No significant differences were observed, and there is insufficient evidence that Biomass is superior to autogenous bone for GBR. However, as the use of autogenous bone requires surgical invasion, thereby causing mobility of the donor site, this paper concluded that biomass is preferable to autogenous bone. This systematic review reports there are no significant differences in the survival ratio between areas where GBR was performed and where the implant was placed within the existing bone. After completely scraping the bone surface, I performed degaussing and grafted a mixture of bypass and autogenous bone collected from the mandible and placed barrier membranes. We exploited the flaps, scraped the bone surfaces, thoroughly placed the fixtures in ideal positions, and then filled with some bone graft material. We placed a barrier membrane on top in a fixed position and suture either row to row or end to end. These images are from a systematic review of the survival rates of implants placed in sites augmented with guided bone regeneration using barrier membranes in partially edentulous patients. In controlled clinical trials, no significant difference in implant survival rate was observed between sites of regenerated and non-regenerated bone. Second stage surgery was performed 4 months after implant placement. 4 months later, I performed second stage operation. The picture on the left was taken when I pressed implants. The one on the right is from the second stage operation. Here are the final procedures. On the left, you see the primary session before the operation and the final outcome on the right. Here is the final outcome. We succeeded in creating a very natural looking state, and it appears that all natural teeth are present in the final result. From left to right, these are X-rays taken before the operation, with the final procedures on and after 6 year follow-up. This is the follow-up after 6 years. Even in this case of implant treatment, we were successfully in creating our natural look, and we should return to the natural looking state as much as possible. This patient is a 43-year-old female. This is the final case. Her chief complaint was an unappealing, acidic appearance of the anterior teeth. This is a primary situation. The smile at the initial visit. This is a classification of alveolar ridge deformity by CBAT. This case is class 1, but with a significant vocal bone loss, a large amount of connectivity tissue needs to be grafted. Now, what conditions should we have at treatment endpoints? Dr. Huger was the first to establish clear treatment endpoints. These include approving the 3 millimeters or less, a full mark plug score of 10% or less, no package, no probing on probing, and no vacation defects. However, attaining this intraoral status does not at all represent or a state in which the true endpoints have been achieved, because we need to ensure correct occlusion and good aesthetics. The true endpoints integrate comfort, satisfaction, function, and aesthetics, in addition to the four things I mentioned earlier. Based on 2008 report by a group of Dr. Lang Nicholas et al., we should reduce the probing depth to 3 millimeters or less. Nicholas et al. Found that the greater the probing depth is, the greater the risk of tooth extraction becomes. Therefore, we have chosen to make it 3 millimeters or less. The crown finishing line is more than 1 millimeter above the gingival margin, or it may be set less than 3 millimeters in the gingival sulcus. We open the flap using a surgical template. If the patient agrees, any tooth at risk of elongation should be orthodontically extruded. We carefully performed osteotomy, taking into consideration the gingival margin of the final restoration. During surgery, it is very important to avoid removing more bone than necessary and avoid removing tissue from areas where no removal is needed. You should use a partial thickness flap. If you open a full thickness flap, there is a risk of demineralization of the alveolar bone and unwanted absorption. A full thickness flap can also lead to long attachment and consequent recurrence of a periodontal pocket due to the fact we can press the gingival in position. Connective tissue was sutured into place. Suturing was done gently without tension. By 1 year after surgery, The gingival margin had increased about 3 millimeters, which is important to consider when forming the bone, setting the flap, and suturing. A 20-year follow-up performed by Jean-Francois Lefebvre et al. At of 100 patients found 854 out of 948 breech abutments were still in function, which equals to a 90.1% success rate. This shows that breech-based prosthetic treatment is a highly predictable treatment, which should be adopted instead of implant treatment when a defect is uh, linked to on both sides by teeth which need prosthetic treatment. Relying on an implant treatment in such case would further increase risks. We used a fiber post corset with META MMA TPP resin. We created a mock-up of the tooth and silicone index to carefully study the amount of tooth reduction which has to be done evenly and correctly. After that, we completed the preparation by setting the finishing margin line slightly shallow without damaging the tissues. This was performed 9 months after surgery. Next, we took the final impression and festival transfer. We made we made another diagnostic workshop and used it to create the final restorations. We decided on the inclination angle, line angle, shape, interdental space, and surface weight before checking the final form. I fitted the final restorations. We used real zirconia crowns. The tooth axes were set based on the upper anterior teeth. We were able we were able to achieve a beautiful outcome. Here are the initial views, and these are the final views. Here you can see a picture and an X-ray of the anterior teeth. This is the patient's face and her smile at the end point. We succeeded in creating a beautiful smile. We have reached the following two endpoints. We were able to create a final restoration that took into consideration the following extra aesthetic factors: tooth position, shape, size, length, color, tooth axis, embellisher space, cervical line, amount of teeth visible, in the mandible, and the anterior coupling and exclusion at the molars should also be considered. In addition, the periodontal tissue should be healthy with no bleeding on probing. All probing depths are 3 millimeters or less. The humerus fracture is 10% or less, and no vacation defects. The patient was very satisfied that we could achieve a successful outcome. Here is a view at 22 months. In conclusion, treatment must be non-aggressive, clean, beautiful, and natural. The most important thing is save any teeth if a good portion of them is still in a healthy state and is expected to remain in function for 10 years or more. When there is no way we can save teeth on in case of tooth loss, then the next best thing would be to achieve two endpoints by by using either a bridge, an implant, or both of them, depending on the clinical condition. In the end, our philosophy is that the most important and rewarding outcome is our patient smile. Here is my email address. If you have any questions, please contact me.
Hi, Dr. Eiji.
Thank you for your time.
Thank you so much for a lecture. I'd like to say some words. I think that today we had an opportunity to watch a fantastic lecture.
Thank
Thank
you,
you so
thank you
much.
very much.
I'm an oral surgeon, and your knowledge about prosthodontics is beyond of mine. I'm sorry because most of those roots I would probably extract, and but you prepared the roots to receive the dental crowns. Amazing, amazing crowns, amazing cases. And by the way, I saw only excellent cases. I observed the excellent quality of the soft tissue and all of that with long-term follow-up. Only only a few doctors has the same of your documentation. The documentation was amazing. It's amazing, your documentation. Thank you so much for sharing your knowledge with us.
Thank you again. Thank you very
Thank you so
much.
much.
Mhm.
Kiano, I'm sorry. We can't hear.
Well, yeah, there were
Okay.
beautiful cases. Sorry, I was on mute there. Dr. Furuichi, Sukushi
Yes.
Kesu, Subarashi Kogi, o Arigato Gozamashita.
Oh,
Beautiful
arigato.
cases. Thank you for your wonderful lecture. We are very impressed and appreciate it. Although there was even a language barrier to get in connection with you, one thing that brings us together is education and knowledge, something that we all love. Amazing cases. Thank you so much.
Thank you so much. Thank
Thank
you.
you so much.
Thank
Thank you
you
so
again.
much, Dr. Eiji. Arigato.
Thank
Arigato. Thank you. Bye bye.
Thank you.
you. Bye-bye.
Bye bye.
Thank you so much.